What is FMD? Is it bruised patches in other arteries, including the... Can't quite see what that says. That looks like my handwriting. How do you diagnose it? What does it mean if you have it? And what do you do to treat it? Does it increase the risk of SCAD? So we know that these two things are associated. Some people think that FMD, as in the irregularities that you get in other arteries, are, if you like, a result of localized little healed dissections which have occurred in bigger arteries where it can't actually cause any damage in terms of blockages and compression. I think the answer, broadly speaking, is that we don't know. And this is one of the reasons that we are working with the FMD European Study Group to make sure that information that they learn about FMD, we are also informed of and are learning alongside them, and vice versa, things that we are learning about SCAD, we're also feeding into their FMD project. So if we get the EORP funding that I mentioned earlier, what we hope to be able to do is to make sure that the questions that we ask SCAD patients are also being asked the FMD patients and vice versa, so that we can really integrate the research program to try and answer all of those questions. However, overall, I am much more relaxed about FMD than I think perhaps quite a lot of people are. I think it's something that academics who are interested in SCAD have become very excited about, because it's consistent with this idea that the problem in the arteries isn't just localized to the coronary arteries. But I think its clinical importance is much more questionable. As in, does it really matter? It's there, it's interesting, it tells us something about the pathophysiology, but I think it's probably only clinically important, rarely. Harriet. Getting back to work when you have your own business is a bit different. Do you have advice on what to do when you can't count on sick pay and other benefits we may have available? Or what other benefits do we have available? Are you able to answer that? It's a tricky one.
Yeah, that may be a question that's best answered directly to the individual who asked it, rather than answering it in this forum. And it's something that I would certainly be happy to pick up with whoever wanted to answer it, rather than try and answer it now, because it's potentially quite a long answer, I think. But if anybody else has the same question, very happy to answer it directly. And if you want to get in touch with me via Facebook or via Karen, very happy to answer it on an email or on the phone.
Perfect. I'm all in favour of long answers, as you know, so I'll go back to some of my own. Right. Any advice about helping family members who need to, oh, this looks like another one for you, who need to take time off work to look after or take on more family responsibilities from a SCAD patient?
No, potentially their compassionate leave is one option. Lots of employers will offer a certain amount of compassionate leave. Also, as well, if you have caring responsibilities, you can approach your employer. Many will be more benevolent if you have caring responsibilities. You also have the opportunity to apply for flexible working nowadays, but that is a permanent arrangement and is something that you would need to talk to your employer about, and it is a formal arrangement, but it does offer you a greater degree of flexibility in terms of your working hours. Obviously, there are financial implications to that which you would need to take into consideration, but that certainly is an option for you.
Thank you very much. I think I'm going to need some post-traumatic growth after I finish this same question. Right. When will we get the posted feedback from our research day? I can give a bit of an insight into this. This has been challenging on a number of levels. It's been challenging in terms of the getting the ethical approval in place for particular formats of response, and also getting these things reported. What we have managed to achieve is that we have finally managed to persuade our radiologists to look over the MRA scans. These are research scans, so they are not reported on the NHS. And the reason that they're not reported on the NHS is that it would cost us around £250 per scan per patient for them to be reported. So if you've had a CT scan, an MRI of your heart and an MRA, £750 times 130 patients and 30 healthy volunteers, it gives you an indication as to the costs of reporting. So what we have to do is I have to go and flirt with the radiologist, which is, since I've had a reduced amount of hair, has been less successful. However, they have agreed to oversee these scans. We have then struggled to get approval of a letter that we can send out from the ethics. And what we are going to do is we're going to use the ethically approved GP letter, which we will try to copy to patients. And it will have a short report that we will send out. This will hopefully, I'm hoping will happen in the next probably weeks to month or so to get the radiologists to have their final look. What is it going to say? What it is going to say is it's going to refer to things which are clinically important. And essentially, if you have not already heard that there is something clinically important on your scan, then what your letter is very likely to say is that there is no clinically important findings which will require a change in your management. That is what it will say. What it will not say is details of the research findings, okay? So things like subtle FMD on the scans, okay? In order to do those analyses at the moment, what we're doing is we're, as you know, involving the European FMD group to have a look at those, to look at them blinded. We've talked a little bit about that. Those kind of pieces of information are not going to be available for a little while, and also they are not clinically relevant. And I don't think it's actually necessarily helpful for me to come to be sort of saying, well, we've done, on the research assessment, we found that you've got a little bit of additional tortuosity of your, left inferior suprasplenic artery. What does that mean? So those kind of subtleties will not be reported. So what we are going to try to do is that all of those patients who've come up for a research day, we will send what the ethically acceptable document, which is the GP document, with an amended short report for each of those scans as soon as the radiologists have completed their oversight, because they're not reporting, they're overseeing. So I hope that answers that question, does it? We are doing our best. It has been a saga of Scandinavian proportions, which we're trying to sort out. What's the difference between CT angiogram and standard angiogram in clinical terms? Is CT angiogram a better option for SCAD patients? The answer to that question is it depends on when. So for the diagnosis, a coronary angiogram, a conventional coronary angiogram, which most of you will have had, is better. Why? Because a CT angiogram has a lower spatial resolution. And because dissections tend to occur into the more distally, as we've shown in some of the pictures earlier on, further down the arteries, CT isn't a very good diagnostic tool for when you present. So when you're in A&E with chest pain, it's not a great tool. But it is a more useful follow-up tool. So once we know where the dissection is, to look and see whether it appears to have healed okay, so we can make decisions about your antiplatelet therapies, for example, that is where we think it is more useful. And partly the reason for that is that there is some evidence that the risk of, I talked about iatrogenic dissections, those dissections which are caused by the procedure itself, that iatrogenic dissections are, there's an increased risk of those in patients who've had spontaneous coronary artery dissection. And for that reason, unless we have to, and sometimes we do, if you come back in with chest pains that we're worried about, but unless we have to, we try to avoid repeat angiograms because we don't want to do more harm than good. Antiplatelets make sense when you have stents to prevent clotting. I have the newer absorbable stents, therefore does it follow that antiplatelet things are no longer required once they have absorbed? It's a $1 million question. The absorbable stenting companies' advice at the moment is that you continue to treat them as a normal stent. Some of the recent data supports that, which suggests that there is still some signal of late stent clotting, even in absorbable stents. So at the moment, definitely the answer is no different to other stents. Do stents have to be replaced, given they are in place for a number. Getting increasingly concerned, and my daughters have noticed this, that I find that I'm looking over the top of my glasses to read rather than through them. Has anybody else noticed that? Anyway, do they have to be replaced after a number of years? The answer is no. If you have stents, particularly traditional metal stents, they will stay. Over the course of time, they get bedded into the vessel walls. So if you were flying through the artery and looking around you wouldn't be able to see where they are. They just become part of the structure of the wall itself. They do not need to be replaced. So I still have chest pains. Somebody who's relatively recently had a SCAD but is still needing to use a GTN spray several times a day. What can I do and what should I take? I think that we might try and specifically contact that person about that rather than deal with it generally, because I think it's going to be a change in tablets. So maybe if you'd maybe drop us a line on the email, then we can try and maybe get to see you and talk about your medications. Could a SCAD patient have dissections on other places than the heart, in other places other than the heart? The answer to that is that yes, there is a recognised risk of dissections in the arteries that go up to the head and neck, occasionally the vertebral and the carotid arteries. It's not a common thing, but there is an association. I think it's not a strong association. So again, I did at one point approach the people who are interested in carotid dissections, and they didn't feel that they saw coronary artery dissections, particularly in their population. So probably yes, but not commonly. Insurance premiums have tripled since SCAD, and having trouble with specifically identifying SCAD in terms of its risk and what to do. Is work being done with underwriting to improve the understanding and reduce premiums? I mean, what I can say is a couple of things. First of all, the British Heart Foundation, the British Heart Foundation website, has a very excellent section on insurance after heart conditions. And they have a list of insurers who tend to be a little bit more sensitive to people who've had heart conditions. So if you are struggling to get health insurance, then I think the British Heart Foundation either have a look on the website or maybe even contact them. They do have quite a good section on this. In terms of what is being done to improve or reduce premiums, we are certainly happy to work with you and your insurers if that is helpful. So sometimes insurance companies might write to us and ask for information to talk about what is known about risk for something that's unusual. We're happy to do that if that's helpful. Are all worldwide studies being collated as one, or are the findings separate at the moment? Welcome to the world of research politics. So the answer is we feel quite strongly that a collaborative effort is very important. And that is hopefully exemplified by what we're doing with the European study and our work with the Americans. I think in many respects we've tried to take the lead in trying to nudge people together. It is always a challenge because all researchers need their own outputs to demonstrate that they're delivering to their employers. And unfortunately, research is done on a named basis. So we can't just be the UK SCAD study. We have to be me personally. And then you get scored on all of that. I'm hopeful that we can put that to one side. Certainly there's good signs in terms of the meetings that we're having at the AHA tomorrow. And with our European partners. That one doesn't have a question. So I think we might answer that one, as it's from somebody who's not here. Will you be working on SCAD research for the rest of your pitiful life? It doesn't say pitiful. I added the pitiful part. Will you ever finish this work? I'll let you know. I've been researching, hobbies, but haven't found any yet. I love my job and work long hours, but something more about getting stressed rather than what I'm actually stressed about. Should I worry about being stressed, as in busy stressed? Stress is a difficult one. The trouble is if you take a room full of anybody, often you will find a fair proportion of people who are feeling stressed at any given time. people talk about stress in association with spontaneous coronary artery dissection, and certainly I think that we do see that there is some association with increased levels of emotional stress prior to events. However, that link is a difficult one, just as it is with any medical condition. And certainly, I think it is difficult to say that there is a firm link between having, if you like, a busy and active and stressful life and future risk. I think that would be tenuous from the data that we have at the moment. My view is it's the most important thing is, making sure that you are moving forward in the best way and most positive way for you. And you have heard from different people today about how they've done that. There will be some people around you that you'll have talked to who will have gone straight back to work and gone back to, essentially as quickly as possible back to where they were before. Other people that have adapted and changed their lives to try to get into a place which they feel is better for them going forward. I think the most important thing of all is moving forward in a positive fashion. As I had SCAD whilst exercising, how can I set my own limits in the future? I think exercise, I am, as many of you know, very positive about. I'm very positive about cardiac rehabilitation. I think we still get emails and letters from different places saying, oh, we're very worried about cardiac rehabilitation in this person who's had spontaneous coronary artery dissection because we're worried that it's going to make it worse or something bad is going to happen. And there is very good data. There's 2 published papers now showing that exercise rehabilitation after dissection is entirely safe. I think I'm hopefully maybe not reiterating what was said upstairs. I wasn't there. But I think that is very important. In terms of the exercises that I would do, it's fairly obvious. The things that are sort of short, sharp shocks, the sprints, the heavy weights, those kind of things I think are perhaps a less good idea. Then the long distance walk, the gentle jog, and those kind of things. Did I answer the question? Can I set my own limits? I guess it depends what your limits are. I think it's common sense. Can you discuss the suitability of HRT during the perimenopause? So we've had a few conversations about contraception and HRT today. The issue is that we are extrapolating from the fact that this is a condition which occurs in a higher proportion in women. It has an association with pregnancy and the perimenopause, and therefore we can reasonably say that there's an association with female sex hormones. And we're extrapolating that to make assertions about whether hormonal contraception or HRT are safe or not. And that's the extrapolation. That's what it is. There is no data out there that says, we have analysed this population of patients who were taking this, that, or the other, and this particular population were at higher risk than the other. We hope to have some more of that data coming up, as we analyse from the questionnaires that you're going to be sent. And then it depends on who you talk to. So the Americans are largely, quite conservative about these things. They tend to be largely averse to hormonal contraception or HRT. So they would recommend barrier contraception first, non-hormonal coil through to hormonal coil, then progesterone strategies for contraception, and would avoid HRT, or if required, go for local options rather than systemic options. That's what the Americans would say. I think that I'm perhaps a little bit more liberal in terms of saying, well, I think at the moment the evidence is not there to say that we know exactly which hormonal strategies are better, which hormonal strategies are worse. So, I think that's probably as much as we can say. Those are the facts that we know. Is SCAD a progressive condition? Are our chest pains and other symptoms, like palpitations, going to go away with time? I think the answer to that is probably yes. I think that our experience of looking after patients is that the chest pains, the symptoms, tend to ebb away over time. They tend to be the most evident very early after the event. They can continue for some time. Okay, and again, we were talking about a specific set of questions earlier on. We can try and do things with the medications to tweak things around to try and help with symptoms. But I do think that over time, again, experience of talking to people at different stages suggests that those do improve gradually. How can I know that I won't have another SCAD? You can't know that you won't have another SCAD, but you can not focus on it particularly. I think the most important thing here is that there is always some risk in life. When you cross over the road to get to the other side, you take a risk, but you don't particularly think about it. Yes, there is a risk of recurrence. Actually, the likelihood of not having a recurrence is far greater than the likelihood of having a recurrence. And as I said earlier, I suspect that the published recurrence rates from the series that we know about at the moment may be overestimating that risk. So you can't be sure, but I think I would move on and cross the road carefully. Is there a link between preeclampsia, postpartum hemorrhage and SCAD? Well, I think we don't know the answer to that. We're certainly very interested, and you'll see some of those questions in the questionnaire when it comes your way over the coming weeks. And again, hopefully those bits of information that you share with us at that time we can look at in a bit more detail. If SCAD is an acute condition, why is it universally treated with drugs as if it were a chronic condition? Can the drugs be stopped? And I'm trying to do a little banter through drugs earlier on. I think the questions that people have, or the reason that people end up on tablets, is that they're trying to think about whether there are medications which reduce the risk of having further problems. And the answer, of course, is that we don't really know in SCAD because we don't have clinical studies to demonstrate it, yes or no. So we have to work on our logic from what we know about the condition, from our experience of working with patients. And I think I did go through the drugs sort of specifically in order what our views are, but I also did emphasize that those are our views, and there are other people who have slightly different views, and that results from the fact that these are clinical judgments rather than evidence-based from clinical studies type responses. But again, having a growing community of people with SCAD potentially enables us, where these questions arise, to think about clinical studies in the future. And again, that's one of the really important things about hopefully keeping engaged with the research as we move forward, because we're going to keep needing you. I have a high blood pressure since SCAD, which can't be controlled. Does anyone else have this? I had high blood pressure when younger. I don't think that is a common issue. It is probably more likely that you have hypertension, high blood pressure, which is a very common problem. And the thing with very common problems is that if you then have a rare one, we try to make links which aren't necessarily there. And I suspect that the high blood pressure that you have is the same condition that other people have in terms of high blood pressure, and it's essentially coincidental that it's interacted with your SCAD. There were other people who have high blood pressure. As we get a little bit older, that becomes more prevalent. So perhaps not surprisingly, in some of our SCAD survivors who've had their events when they're a little bit older, high blood pressure gets a bit more prevalent. I think I'm starting to get halfway down now. Anybody still awake? On balance, I thought that said balding to start with, which I thought was a bit rude. On balance, it says, and based on your research and experience, is there a probability of recurrence of SCAD in patients who are fully stented? I don't know the answer to that. I think logically it is, I don't think, possible to have a recurrence within the stented segment because the artery is essentially scaffolded. What we do know is that recurrences, when they do occur, don't necessarily occur in the same place. So they may occur somewhere else. So having lots of stents in one spot doesn't necessarily protect you from having event in another place, I'm afraid. I'm 55 and have a high cholesterol. I have a great deal of sympathy with this. Should I take a statin or is it contraindicated? Well, it certainly isn't contraindicated, okay? So it's a bit like the blood pressure that we talked about a moment or two ago. If you have a high cholesterol and your overall calculated risk of having the other stuff, if you like, the strokes, the heart attacks for a conventional reason is above a threshold, then it is reasonable to take a statin on that basis. But what you're not doing is taking a statin because you've had SCAD. You're taking it just the same as every other 55-year-old who has a cholesterol of that order. We had SCAD described as a tear or peeling of the arterial wall. Is this correct, or is it as a result of a bruise? I tried to explain that, but I think I confused myself. The answer is that I'm not absolutely sure, but I'm a bit more bruise inclined at the moment, and I hope that by analysing more of the angiographic data and the intracoronary imaging data, we can firm up a bit on that. I think some patients definitely have a bruise. What I'm not sure is whether all patients start with a bruise, or whether there are some patients who have a tear and some patients that have a bruise. But we're working on it. What is my opinion on taking coenzyme Q10 to counteract, I think it says, the side effects of statins? Well, I'm not that keen on statins for the reasons that I've alluded to already, and I'm even less keen on taking something else into the mix that's to counteract the side effects. Generally speaking, I'm not that keen on supplements because I don't know really what they're doing. I think people sometimes will find a middle place where they find something which is helpful to them, and I think that's entirely a reasonable thing to do. But I wouldn't necessarily write that down as something I would advocate. I had sepsis 4 years before my SCAD. Could this have changed my heart or be a contributing reason? I suspect you've just been unlucky. Sorry, but I don't think it's likely to be connected. Are ice baths and saunas okay? Generally, I avoid them. So I can't comment. No, I don't think that there is any particular problem with that if that's your thing. Enjoy, really. Are there any survival rate statistics, i.e. how many people have a SCAD survive and how many don't? No is the answer to that. And part of the reason for that, and I mentioned the pathology work that we're doing, so we're working with a lady called Professor Mary Shepherd, who's the most fantastic Irish lady from George's in London, who is a pathologist who has a great deal of interest in cardiac conditions and sudden cardiac death. And I think one of the things that she has published is that this is actually a very difficult thing to diagnose in people, unfortunately, who've had sudden death. And again, rather like it's not so easy to diagnose in the living, it probably is also underdiagnosed at post-mortem. So I don't think we know the answer to that question at the moment. It certainly isn't common cause of sudden death, though. Do you think that extreme stress or grief may be a precursor to a SCAD event, even if it happened years before? Are you looking at this aspect? We've talked a bit about stress, and there is potential for association. Stress is hugely difficult as a research subject to link with things. It's proved to be very difficult, even with conventional coronary artery disease, to say that stress equals a risk factor. It's very, very difficult because it's so common, it's so variable to study it. But you will find some questions on it in the questionnaire, and hopefully we may gain some insights from those. I'm going to collapse myself in a moment, so I might do another couple. Would any other health condition exclude you from being able to participate in the research study? No, but obviously we would like to know about it. And in fact, in some cases, we might be interested in it. What do we have to do to donate our bodies to SCAD research if the worst case scenario happens? Well, it won't happen. I think what we do have on the consent forms for the patients who come, I think, is a slot about about organ donation and those kind of things. It is in there, and one of the reasons is to give us the opportunity to be able to do that kind of research going forward, if we feel that there's an opportunity to do that. So it is actually there. I'm not sure in terms of sort of body donation kind of thing. That's quite complicated. And I'm not sure that we would be able to do that ethically at the moment. There are ways in which you can. It's a serious question, though. There are ways in which you can do it through universities. I think that's kind of us. Right, I'm going to do this as the last one. Congenital predisposition. Would our hearts look different than a normal heart if it was scanned in the first year of life? No. Okay? So your heart looks basically normal before you have a SCAD. And and other than for the injury that's caused by the SCAD, if you're conservatively managing it healed, you probably would struggle to find any abnormality after the healing has occurred. So certainly there, at the moment, we don't have any screening test which can be used to identify at-risk individuals. Obviously, a lot of the research will be looking at other things like the vascular hyperreactivity and things like that we might be able to look at in the future. But I emphasize again that the evidence does not suggest this is a strongly familial condition. So I'm sorry if I haven't answered your question, but I can see that there's 4 or 5 people at the back who've been stretched out, and I think perhaps that should be enough questions for one day. So thank you for putting up with my ramblings.